And I'm now pleased, very happy to welcome Dr. Himisha Beltran. We're going to speak about a very important topic, which is how do we assess the biology of the disease.
Thank you, Bertrand. Thank you. It's wonderful to be here really very grateful for the invitation. So I'll be talking about when to do and think about doing a new biopsy in CRPC. So as we know, castration-resistant prostate cancer is a heterogeneous disease, and we think about genotyping to identify patients that might be most amenable to PARP inhibitors, immunotherapies, or other drugs in development. But there are also phenotypic changes and underlying resistance mechanisms that can impact how a patient responds or doesn't respond to therapies, but it's not something that we routinely assess clinically when making clinical decisions. One way to assess phenotype is through doing a metastatic biopsy. And in CRPC, particularly as you get to later and later stages of the disease, you can see a lot of heterogeneity in histology, and importantly, heterogeneous expression of the androgen receptor, PSA, PSMA, and other targets. So I think it's going to be increasingly important to think about phenotype as it can impact the expression of cell surface targets. We do have PSMA imaging, but we don't have imaging for many of the other new drugs that are in development targeting the surfaceome. I think it's also will be important to know about phenotype when thinking about the best way to monitor a patient. Does the tumor make PSA or PSMA? Should we be using ctDNA fraction to monitor a patient instead? And phenotype can also help us select lineage-directed therapies, the neuroendocrine phenotype, which is not the most common, but important to recognize. So when would I consider a new biopsy? I would say in the setting of progressive disease with low PSA, low PSMA negative lesions, atypical sites of METs. And one reason to do it is to rule out another cancer, as our patients can get second primaries. If small cell carcinoma is identified, we could consider a small cell carcinoma regimen. I might use that tissue to enroll in a clinical trial, especially those that are assessing new targets that are acquired in later stages. And I might use that tissue to repeat genomic analyses, as primary tumors and ctDNA do have advantages, but also some limitations, and there's additional information that could be gleaned from doing a new metastatic CRPC biopsy. Although one could argue, why do a biopsy in everyone? Biopsy in everyone is likely of low yield. It's invasive. It takes a while to coordinate. It might delay or may challenge the initiation of next-line therapy. You could consider platinum chemotherapy even in the absence of neuroendocrine histology based on aggressive variant clinical features or even potentially combined tumor suppressor loss. But I would say I still think it's important to know what we're treating. This idea of this concept of histologic transformation from adeno to small cell carcinoma is important to recognize. It happens in lung cancer too, and some other cancers also that can change their lineage. And the same conversations are happening in those fields as we start thinking about lineage plasticity as a resistance mechanism. So why is it so controversial? If you ask around, I would say some people report never or rarely seeing neuroendocrine prostate cancer, and other clinical reports to say it's up to 15 to 20% of late-stage CRPC tumors. I would say repeat biopsies are not standardly done still, so the true estimation is really unclear, but it's probably somewhere in the middle. But importantly, I think there's a lot of variability amongst pathologists. If you ask 5 pathologists to look at a CRPC biopsy, you may get different opinions on how to call neuroendocrine prostate cancer. And even within that, this disease spectrum, there can be a lot of heterogeneity. So I think one big advance would be, could we get our pathologists and our clinicians to come together to at least standardize a framework on how we report metastatic CRPC biopsies in clinical trials, but also in clinical practice. So to this end, we recently held a workshop bringing together some expert GU pathologists and clinicians to think about what kind of things could we standardize in a report that is applicable not just to specialized centers, but could be implemented in community practices and across clinical trials. And so what we propose is classifying metastatic CRPC tumors first based on morphology, adenocarcinoma, poorly differentiated carcinoma, small cell carcinoma, or other. And then we discussed a series of IHC markers looking at AR status, AR expression itself, AR signaling, neuroendocrine marker expression with a priority list based on the antibody characteristics, but also the availability of tissue and the antibodies in pathology departments. And then proposed adding Ki-67 for proliferation status. And so one could envision if we started to see similar reports reports, even though I think we don't really know what the clinical significance of all possible variations of these are, we could be able to gather that data in our practices and then add molecular data or other markers in the future in the context of trials. It is important to know if neuroendocrine histology is there because certain targets, like DLL3, is expressed only in poorly differentiated neuroendocrine carcinomas, including prostate, lung, small cell bladder cancer, poorly differentiated GI tumors, and it's not expressed in prostate adenocarcinomas, even in those cases with tumor suppressor losses. So it is very specific to the neuroendocrine phenotype. And the DLL3 targeted T-cell engager tarlatamab was recently approved last year for small cell lung cancer. This is a drug that binds DLL3 and CD3, and according to NCCN guidelines, a patient with neuroendocrine prostate cancer post-platinum could be considered for small cell lung cancer regimens, so it's important to recognize. There are limitations to a tumor biopsy. I think one of the biggest limitations is that single-site biopsy doesn't capture what's happening across metastatic sites. And so a lot of work in liquid biopsies and molecular imaging to complement or potentially even replace biopsies in the future, cell-free DNA, CTCs, molecular imaging. Just a plug for the NEMO assay, a targeted cell-free DNA methylation panel that we developed with Francesca de Michelis, which is a plasma test to quantify tumor fraction, as well as provide a phenotypic evidence score along a spectrum of adenocarcinoma to neuroendocrine prostate cancer. PSMA tends to be negative or lost in neuroendocrine prostate cancer, in part due to loss of androgen receptor, which is an important regulator of PSMA. Also, PSA tends to be low in these cases. And we know that some patients are not eligible for lutetium PSMA therapy. And even within PSMA-positive lesions, you can see heterogeneous expression of PSMA. We found that it's not always the case that PSMA low or PSMA negative lesions are AR negative. Certain features, such as the liver microenvironment, can suppress PSMA expression, even with strong androgen receptor expression. More recently, we've been using combined PSMA and FDG PET in preclinical studies, not for selection, but to think about how to incorporate these combined modalities in monitoring response and resistance to lutetium. So lots of interest, of course, in this meeting about refining PSMA as a biomarker in CRPC. And I do think that it will be important to do biopsies in the setting of PSMA negative lesions to better understand the biology of PSMA negative disease and identify complementary molecular imaging modalities. We've looked at some of the various cell surface markers across CRPC, and yes, there's overlap of many, but there are still some patients that don't express any of these, and I think there's still opportunity for discovery when it comes to new imaging biomarkers. DLL3, developed by Michael Morris and colleagues at Memorial, is feasible to do by PET imaging and may complement PSMA and FDG PET in identifying neuroendocrine prostate cancer non-invasively. We found that PSMA low lesions, whether they're neuroendocrine or not, tend to upregulate amino acid transporters. And in preclinical studies, these PSMA low lesions were flucyclovine PET avid. And so we now have a clinical trial, a pilot clinical study at Dana-Farber in collaboration with Heather Jacine from Nuclear Medicine, doing combined PSMA PET, gallium PSMA PET, and flucyclovine PET imaging in patients with PSMA low or neuroendocrine prostate cancer. So just to conclude, metastatic prostate cancer can evolve during progression, and it can acquire phenotypic changes that we can see on biopsy that can impact response to therapy and outcomes. I think a repeat biopsy could be considered in patients with atypical progression, low PSA, low PSMA, high FDG, aggressive disease to evaluate for histologic changes like neuroendocrine prostate cancer, cell surface target expression, which can be dynamic, and understanding the biology of target dynamics could hopefully optimize patient selection, inform biomarkers and combination strategies for the future. And I'm hopeful that combined imaging and liquid biomarkers will complement or hopefully replace the need for a metastatic biopsy in the future. Thank you.
Thank you.